Okay, well, welcome everyone to pediatric teaching again today. Now, in the first three sessions this year, we've talked about just an overview of pediatric training. That was the start. And then we talked about the deteriorating child, how common it is to see children deteriorating on the wards, and we need to identify them and to have ways to prevent that, and also to deal with them when they do. And we also talked about the next one was on the commonest reason why children come into hospital, pneumonia and bronchiolitis. So we talked about pneumonia, both simple pneumonia and also complicated pneumonia. And today I thought we'd talk about fever in children because it's just so common. We see it so often, and yet we often don't take the time to understand what the causes of fever is, what the biological basis for a child's fever is. And so I thought I would just go through some of those concepts today so we can look a bit more in depth into fever. So we're going to be talking about the normal mechanisms for body temperature regulation. So to understand fever, we need to understand a little bit about the normal body temperature regulation. We'll talk about the pathogenesis of fever. So we'll introduce concepts like pyrogens and the part of the brain where fever comes from, the hypothalamus. We'll talk a bit about prostaglandins because they're the mediators of fever. And also we'll talk about some of the effector mechanisms of fever, like the parasympathetic and sympathetic nervous system, because they influence whether we can mount a good response to fever or whether we can't. So we'll talk about those things in terms of the biological basis for fever. We'll talk about the classification, like beyond biological basis, there's the clinical, the practical clinical things. And WHO has a very good classification of fever, I think, that can help us. So we'll talk about that. We'll talk about the etiology of fever in Papua New Guinea and in other tropical countries, because there's some good data on the different causes of fever, and they might not be just what you think they are. Sometimes the causes of fever are often different to what we think. I'll say something about why some fever is good for you, because having some fever at some times is actually good for you. And we'll talk a bit about heat stroke. So that's a lot to get through, but let's delve into fever today. First of all, I wanted to just review what happens with our autonomic nervous system. So when we're exposed, you all know the downstream effects of this. Like if we're exposed to cold, then we have like if you're in a very cold environment, then you might not know it, but you have activation of your sympathetic nervous system, because that causes like cutaneous vasoconstriction. That's why children who are exposed to cold have like cold limbs and vasoconstriction. They also have a higher metabolic rate. If you're exposed to cold, then the body tries to generate heat by burning up metabolites, by burning energy. You also have this thing called piloerection, where you might have noticed where your hairs stand on end on your skin, and that tries to trap heat within your body. All right, so you're less likely to lose heat. It's a bit like, it's a primitive reflex, I suppose, a little bit like having fur maybe in very evolutionarily past, or in animals having fur. We humans have this thing called piloerection, and that's a sympathetic nervous system response. And then, as I said, you have thermogenesis, which is just your body tries to generate heat from energy. So uses up glucose, burns fats to generate heat so that your body can stay warm. That's what happens if you're exposed to cold. If you're exposed to warm, the extreme heat, however, then you get activation. This is the adaptation. You get activation of your parasympathetic nervous system, and that causes vasodilatation. So when we're exposed to a very hot weather, then we get peripherally vasodilated and we start to sweat, and all that's designed to lose heat. If you have peripheral vasodilatation, then the blood goes to your limbs, and you can more easily lose heat from your limbs. If you have vasoconstriction, then all the blood is more of the blood is circulating internally, and you have no way of losing heat from your blood. So peripheral vasodilatation and sweating allows us to lose heat. So that's what happens when we're exposed to either extreme cold or extreme heat. That's what should happen. And then, of course, there's your behavioral response. If you're exposed to cold, you put on warm clothes. If you're exposed to heat, you take off clothes and you move into the shade and you drink water. That they're behavioral responses to extreme temperatures. And there's an autonomic nervous system response to extreme temperatures. Where all this happens is the hypothalamus, because that's where your heat and cold receptors are. And it's not that important to know, but it's just a small part of the brain, which is close to the brainstem, just at the upper part of the brainstem, which regulates our body temperature most commonly. And there are some people, some children have, if they have a brain injury, they may have disordered heat regulation. And so they might always be cold. Their temperature might always be low. So there are some children with cerebral palsy who've had a brain injury, for example, where their hypothalamus is damaged or affected, and they may always have hypothermia because they can't mount a good, strong response, or they might have intermittent fevers because their hypothalamus is functioning abnormally. So that's where most of the regulation of heat and cold happens at the hypothalamus. And this is an MRI scan just showing where the hypothalamus is. It's just above the brainstem. This is the midbrain, and this is the hypothalamus. So let's go on to, we talked about the normal regulation of heat and cold and our body's response to that. I want to now talk about the causes of fever. And sometimes when we talk about the causes of fever, you think, oh, we've got to go to malaria, or we've got to go to a particular pathogen. Now, I want to go back a step and say that there are broadly two sorts of types of fever when you think about the generation of fever. And one is pyrogenic causes of fever. Pyrogens are, they're most commonly, pyrogens are external, and they're any virus or bacteria or parasites or fungi or infectious disease or endotoxin, which is just a part of an infectious disease, or even impurities in some drugs. They can all act as pyrogens. And the pyrogens in our body get dealt with by the immune system, and the immune system can lead to a stimulation of fever. And I'll explain how that happens. But pyrogenic causes of fever happen because the pyrogens end up resetting the core body temperature, which happens in the hypothalamus. Normally, our core body temperature is set somewhere between 36 and 37 degrees, isn't it? That's our core body temperature. But when you're exposed to viruses or bacteria that are acting as pyrogens, then that resets the core body temperature, sometimes to a much higher level, like 39 or 40 degrees. Then your body responds by generating that sort of heat and generating fever. They're pyrogenic causes of fever, but there are also non-pyrogenic causes of fever. And I think these are important, especially in tropical environments. Sometimes we don't recognize it, but there are lots of babies, especially babies, that are their fever when they present is not because of a sepsis or an infection. It might be, but it also could be because of heat stroke or heat exhaustion. And in those circumstances, the set point of your body temperature, what happens at your hypothalamus isn't changed, but the fever is due to some circumstance that interferes with the normal mechanism of heat loss. All right, so we have our mechanisms that we talked about before for heat loss, like vasodilatation and sweating, and behavioral responses like we move to the shade, or we take off our clothes, or we drink water. All of those things are normal responses to heat, to exposure to heat. But for some reason, some children, because of their environment, may not have those responses. They may not be able to mount those responses. And that particularly happens in young babies, in infants who are exposed to extreme heat. We'll talk a bit about heat stroke at the end. So let's move on from that. And I want to talk a bit about how pyrogens cause heat. So that's the next step. Remember, I said there are pyrogens, and we talked about the pyrogens being outside the body, those things like viruses and bacteria and parasites like malaria or fungi or endotoxin. Remember, the particles of bacteria or impurities in drugs, they can all be pyrogenic. They can stimulate a fever in our body, right? Then you have these things called endogenous pyrogens, and they're chemicals that are produced in our body by an inflammatory response. They're produced by neutrophils. Remember when we have an infection that activates neutrophils and they produce chemicals, and they're often, you don't need to know them necessarily, but like they're called IL-1 or IL-6 or TNF alpha. They're called interleukins. They're just mediators, chemical mediators. And the neutrophils consume or phagocytose the virus or the bacteria. Then in response to that, they produce these endogenous pyrogens like IL-6 or IL-1 or TNF alpha. They're the interleukins, right? So these exogenous pyrogens, remember I said the viruses, they get phagocytosed by neutrophils, and then you get interleukins being produced, and they act on the hypothalamus, and the hypothalamus then produce prostaglandins. That's what comes from the hypothalamus, and that changes the set body temperature to a higher level. So it might change it to 39 or 40 degrees, and then those prostaglandins, they cause the body to increase heat production and to decrease heat loss by the autonomic nervous system responses that I mentioned before. So it's useful to know where a pyrogenic cause of heat comes from, a pyrogenic cause of fever comes from. And we have ways of tackling that. So aspirin and non-steroidal anti-inflammatories, they counteract prostaglandins, as you know, and so therefore that can reduce fever because it's acting on the hypothalamus to reduce the production of prostaglandins. So that we have ways to reduce fever. So the body's response when the higher core body temperature occurs is that when you're exposed to an endogenous pyrogen, you often feel chills, and you think, why am I feeling cold? But your temperature is hot. And that's because your body says your temperature should be 30, 39 degrees, but it's only 37. And so you feel cold, right? And that's why you have chills and rigors, because your body is warming up, right? And so there are mechanisms to warm to that new set point. That's what, when you see a child with an infection and they're getting a fever, it's because when they've got chills and rigors, their body is warming up. Right? It's going from 36 to 37 to 38 to 40 degrees because of their body is telling them they've got a new set point, right? And that involves like the parasympathetic nervous system. So you get rigors and shivering, and you have an increased metabolic rate and general generation of heat. Seem to have lost the slides here. I'm not sure why. Okay. And then when your body reaches this artificial new set point, then your countermeasures to fever, they set in, and that can lower the temperature, right? So once your body has reached that set point, then you have activation of the parasympathetic nervous system, and that's why you get vasodilatation. When you see children who are really hot, they're often red and inflamed, and they're really vasodilated, and they've got a bounding pulse because they've got blood flowing to their peripheries, and their body's trying to lose heat to get it back to that, lower temperature to stop them overshooting. And then you start sweating. That's all the parasympathetic response to fever. And your body's trying to lose heat at the same time as it's trying to maintain that temperature of whatever the new set point is. Okay. So we've talked about the reason why our temperature changes. We've talked about the pyrogenic causes of fever. I just want to talk now about the causes of fever in tropical countries. Oh, sorry, I'm just going to go out of this slide sharing and then share it again, because I think we've lost it here, unless I can. No, I'll go out and I'll come in again. Just stay there, everybody. I'll just go in again. In the room, we just lost it. That's easy to forget. Here we go. It doesn't seem to be back. Sorry, guys. Sorry, everyone. Let me stop sharing and I'll start again. Back to Zoom and I'll share again. Okay, we're back in the room. Okay, we'll keep going. Sorry, we'll keep going. For all those people online, we just lost the screen on the main screen. Let's go back. So I wanted to talk about the causes of fever in tropical countries. And I guess in the past, the main cause of fever was malaria, but now we're knowing a lot more about the causes of fever. And this is a study that was done in Tanzania. And I think it's a really good study because it's looked in detail at the causes of fever in children. So these are thousands of children that have come in with fever. And as you might expect, that quite a few of them have malaria. So 9% have malaria, but over a third, 36% had upper respiratory tract infections. That won't surprise you either. They're really common, aren't they? Upper respiratory tract infections are common. About 10% have non-radiologically confirmed pneumonia. So they might have had like bronchiolitis or some other thing. And about 3% had radiologically confirmed pneumonia. So they had consolidation. So probably they had pneumococcal, pneumococcal bacteria or some other Haemophilus or something like that. 8% had gastroenteritis. And then other things like urinary tract infection occurred in 5%. 5% of all children with fever had urinary tract infection. So maybe more common than we might recognize unless we look in the urine regularly for children who've got fever to see if they've got a UTI. And 1% had skin infections, 11% had systemic infections, so like sepsis, severe sepsis. 3% had typhoid fever, and I know in some parts of PNG that it might be even higher, the proportion with typhoid fever, but that's what it is that it was in Tanzania at the time. So that's just a pie chart showing the breakdown. Several thousand, I think it was 3,000 children who had fever. They broke it down even further. I think it's quite interesting to then think about what was the virus or the bacteria causing those clinical syndromes. Each of these are the clinical syndromes causing fever, but think about the different, think about the different pathogens, the viruses or bacteria. Well, more than half were just viruses alone. More than half of all of those thousands of children with fever were just viruses alone. About 10% were just bacteria alone. And about 10% were both viruses and bacteria. And that's important because many of the bacterial infections we see, there's been a pre-existing virus infection, and then the child gets a bacterial infection on top of that, especially with pneumonia. Usually, the child's had a virus infection, a viral upper respiratory tract infection, then they get colonized with pneumococcus or Haemophilus, then they aspirate that pneumococcus or Haemophilus, it goes into the lungs and they get a secondary bacterial infection. That's the common reason, the common mechanism. So when we think about fever, we often think about bacterial infections or we think about malaria, but a lot of them are virus infections. We treat them with antibiotics, but many of them, you have to understand, are just viruses and they won't necessarily respond, right? So that's important and useful information. And then this is a bit harder to see, but they've then broken it down into the different pathogens causing fever. And of those different clinical syndromes, what sort of pathogens they were. So of those, for example, I'm not sure whether online you can see this, but of those with the upper respiratory tract infection, then some of them were influenza, some of them were rhinovirus, some were coronavirus, enterovirus, adenovirus, and other viruses. Of those that were causing systemic infections, like sepsis in children, like septicemia, right? A lot of them were this virus called herpes virus 6, HHV6. That was, at least in Tanzania at the time, it was common to get HHV6, and also parvovirus. And I think we see a lot of parvovirus here. We might not recognize it, but we see quite a lot of parvovirus here, and it's often in children that have fever and anemia, right? Parvovirus causes both fever and anemia. And then there's other bacteria that caused fever in this, it's like sepsis in this cohort. For example, like bacteremia, hepatitis, mumps, chickenpox, leptospirosis, other things. Then there's the causes of like upper respiratory tract viral infections like adenovirus and influenza. And then the causes of gastroenteritis, mostly rotavirus, and some salmonella and shigella. So I guess you can see from that that the causes of fever are very broad. There's many different causes of fever. It's not all malaria. It's not all pneumonia. There's lots of different causes. And so it really is important that we try to understand all the different causes of fever. So in that cohort, as I said, that if you saw a child with sepsis, then the commonest cause wasn't a bacterial infection. It was actually this HHV6, which I think is actually quite common here too. And it's actually, HHV6 is a common cause of like febrile convulsions. In fact, it's probably the most common cause of febrile convulsions, HHV6. It's not a herpes virus, not a typical like HSV. It's a different sort of herpes virus. I'll explain that in a minute. And 10% of this cohort had malaria. So malaria hasn't gone away from being a cause of fever. 10% of these children, 3,000 children, actually had malaria. But half of those children also had another bacterial infection. They had malaria, but they had a virus, or they had gastro, or they had bacteremia as well. So the point being, don't just think about, it's not as simple as what we might have thought. That there's often in the kids with malaria, half of them will have something else as well. So we need to be aware of that. Okay. Now WHO has this very, I think, good way of classifying fever, and we've talked about this in the hospital care for children training program. But I think it's useful when we are teaching people about fever to think about fever with localizing signs, fever without localizing signs, fever with rash, and fever lasting more than 7 days. I mean, they're 4 groups, and there's quite a bit of overlap between them. And there are some fevers, for example, that can last for more than 7 days, but the children present earlier, so it becomes, there's overlap. That's all I'm saying. Okay. But if we take them individually, like, fever without localizing signs, if this is in the hospital care for children book, things like malaria, or septicemia, or typhoid, or urinary tract infection, or HIV. They're generally speaking, their children have fever, but they might not have a localizing sign. On the other hand, they might. So a child with malaria might have what? They might have, that might help you localize. They might have splenomegaly or something, or they might have anemia. And it's not exactly a localizing sign, but it's a clue. It's a clue that they might have malaria. Or typhoid, what might they have? It's often fever without localizing signs, but sometimes they have signs that give you a clue, such as they might have bradycardia, that's right. They might have other features of typhoid, like constipation or psychosis, or a rash. Yeah. So the point is, children with fever without localizing signs, they might still have some clue, some clinical clue. Urinary tract infections. Now, in an older child, it's usually fever with a localizing sign because they can tell you they've got dysuria, right? But in a young child, the most common children that get UTIs, it's a bit harder for them to declare that they've got those features. So in infants, that's why we need to look, check the urine in a child with fever. And then HIV, of course, there are other features that might indicate that a child's got HIV, like lymphadenopathy, or like, what else? Yeah, oral thrush, that's right. Persistent diarrhea, skin rashes, that's right. So there are, again, clues to the fever being related to HIV, but it's still sort of fever without localizing signs here. Okay. Then there's fever with localizing signs. I put this photograph in because it's a child who came in with fever of uncertain cause. And what can you see in the photograph? His left. His left arm is very swollen. That's right. Yeah, his left arm is very swollen. So what would you think about? He's got persistent fever, like it's gone for longer than a week. What he's got a localizing sign, as in a swollen arm. What could it be? Sorry. Yeah, it could have cellulitis or. Sorry, what? An abscess. Yeah, osteomyelitis or septic arthritis. Yeah, thrombophlebitis. Yeah, he had several of those things. He had a pyomyositis and osteomyelitis, and that was his localizing sign. And he got it because, just to complete the story, he got it because you can see maybe on his right arm there's a little blue patch, and he had a tattoo done by his friends. They did tattoos, and he got an infection from the tattoo. Like only a few weeks earlier, he got the tattoo, got an infection from the tattoo, and of course it caused osteomyelitis in the other arm, right? So that's what sort of infection do you think that was? What do you get from? What causes osteomyelitis typically? Staph, yeah, staph, yeah. So you can get it from the skin, goes to the bone and the joints and the muscles. Yeah, so he had a staph osteomyelitis from his like homemade tattoo. Yeah, but the point is, when fever with localizing signs could be lots of things. Meningitis is a localizing sign, isn't it? We see, neck stiffness or otitis media. In some children, that can be without localizing signs because they're too young. They're just upset and they're distressed. And in older children, we can sometimes see pus from the ear, or they can localize to their ear. Mastoiditis is a localizing sign because they have like a swelling, so you can localize it. Osteomyelitis we've talked about. Acute rheumatic fever can be fever that goes beyond 7 days, or it can be fever with a localizing sign, being what? With rheumatic fever, they get joint pains, don't they? And it's a special sort of joint pain. It's like a migratory polyarthritis, isn't it? Yeah. And then the skin and soft tissue infections, they're localizing. Pneumonia is localizing, isn't it? It's localizing, but many children who have sepsis have fast breathing, don't they? So don't see every child with a fever and fast breathing as having pneumonia. The localizing sign, what? How would you localize the infection to the lungs? Sorry? Dullness and bronchial breathing and crepitations and things, they would have that. Yeah. Sorry, X-ray changes, exactly, they're localizing. A retropharyngeal abscess, they might have stridor or obstruction, right? We might be able to say there's a sore throat, etc., etc. So hepatitis is localizing, isn't it? Because your child's jaundice, you know that the fever's coming from their liver. So I think it's useful to think about fever like that. And in the Hospital Care for Children book, there's like the diagnosis, and then there's the features that are in favor, right? So you can look it up and say, well, what things are in favor of this being hepatitis or rheumatic fever? Okay. And then there's fever with rash. And fever with rash is very common. And we often think of fever with rash as being measles. And of course, we think about that because that's the most concerning condition. And it's the condition we've had to deal with most over the years. But there's lots of different fevers with rashes, isn't there? And rubella causes fever with rash, a different sort of rash. And then there's other viral infections, like I talked before about parvovirus. And have you ever seen parvovirus rash? I think you have, because we see quite a lot, and it gives you like a very red cheeks and a high temperature. I'll show you a picture in a minute. And then there's this one, HHV6, which also gives you a rash as well. Common cause of fever, also a rash. And enterovirus, varicella, chickenpox, you've seen the rash of that. And then there's another condition called typhus. We think of typhoid, but typhus is quite common in PNG, very described very well. And dengue fever, that can cause a rash as well. So what's this? You can see the rash, perhaps. I hope you can see the rash. This is like what's the rash of measles? It's how do we describe it? Is it red? It's red. It's red. I mean, it's red on pigmented skin. It's still red. So therefore it's erythematous, right? Is the color of the rash the same as the color of the skin? No. So therefore it's macular. And can you feel it or not feel it? No, you can feel it. No, you can. Yeah, you can feel it. And sometimes if you look at it in a tangential way, in tangential light, you can actually see the contours of it. Yeah. So therefore it's papular. It's not strongly papular like varicella, like chickenpox. Chickenpox is clearly papular, but measles is papular as well. Yeah, it's not completely flat. Yeah. So measles is an erythematous maculopapular rash. You just need to know the dermatology terminology, right? It just means red raised rash. Okay. Yeah. And always measles goes along with what else? Well, children with measles also have something else. They always have fever. They always have what else? They often have conjunctivitis, usually have conjunctivitis. They almost always have respiratory symptoms, don't they? So they have coryza and always have cough, right? Because remember, it's a respiratory virus. It causes a laryngotracheobronchitis, doesn't it? Particularly a bronchitis, a cough, right? Causes pneumonia as well. But all children have cough and they have fever and they have conjunctivitis and they have a red rash at some stage during the measles illness. Some of them have these things called Koplik spots, right? The white patches in their mouth. And this shows you this boy is like about 14 and he's not crying. This is measles. He's got conjunctivitis related to measles. Okay. So I'm sure you've all seen measles, or hopefully not too much, but we used to see hundreds of cases at a time. And fortunately now we're not, which is good. Okay. Right. This is also a couple of other rashes. So what's this boy on the right? What's this boy got? What is that? Sorry? Yeah, that's right. This is like chickenpox, isn't it? You can see that the feature of chickenpox is you see blisters, but you also see the rash in every stage of development. You know, start off with a red spot, and then it becomes a blister vesicle filled with fluid, and then it breaks open, and then it starts to crust. And when you see a child with chickenpox, they're not all blisters. If you saw all like every lesion is a blister, then you start thinking about other herpes virus infections or something. But if you see all the rashes are in different stages of development, with some crusting, some burst, some just fluid, some just developing, then that's varicella. You can tell for sure. And this boy's also got like a secondary infection of the varicella, right? It's what we call impetigenized, which means he's got like what would be the infection typically of his varicella? What would be the infection? What's impetigo caused by? Is strep, yeah, group A strep, yeah, usually group A strep, sometimes staph, but impetigo is like sometimes called school sores, right? And why is it called school sores? Because children spread it around at school. Yeah, if one person's got it, then all the kids will get it. Yeah. Now, school sores can get onto chickenpox. But mostly when children have school sores, it's just affecting their mouth. Yeah, but it's impetigo. Yeah, and the child on the left, that's rubella. Okay, it's rubella. Again, a fine erythematous maculopapular rash. Okay. Sorry? Yes, it's papular too. It's fine. But it's usually a bit different to measles, where measles is a bit of a coarser rash. rubella is usually, it starts off very much like a fine rash, a fine erythematous maculopapular rash. Okay. Now, we talked a bit about, in the old days, they used to call first, second, third disease because they didn't know the viruses, right? And there was a disease called fifth disease. It's still sometimes called fifth disease, right? And that we now know that's due to parvovirus, right? And remember I said parvovirus is quite common in PNG. In fact, there's some studies done on the north coast of PNG by the IMR, by Moses Lemon. He found that parvovirus was quite a common cause of anemia and fever in children, right? But this is the rash that they get. It's sometimes called slap cheek syndrome, like as if the child's been slapped on the cheek and they've got very red cheeks. So these children, they usually have this febrile illness with rash and on their face and cheeks and their limbs, and it lasts for 7 to 10 days. It's usually quite mild. If you get it when you're an adult, then sometimes you can have painful swollen limbs like other. Excuse me. Hello, it's Trevor Duke speaking. Then they often have very painful swollen joints, and sometimes they have anemia. So remember, if you see a child with fever and a rash and anemia, think of parvovirus. It might be that. Okay, this was a study they did in the Journal of Infectious Diseases. Remember I said parvovirus is like fifth disease. When we're talking about fever and rash, there's also one called sixth disease. And I talked a bit about HHV6 before, and this is HHV6. I won't talk too much about it, except it's actually quite a common virus. Most of us have had it. And most of us, like when we have herpes viruses, then often the herpes virus stays in our body, you know, and that's why you can get like herpes zoster, where you get shingles later on, because it's a herpes virus and it becomes what we call neurotropic, which means you have it when you're a young child and then it just stays in your body. And the chickenpox virus sometimes stays in your neural ganglia. And that's why then it comes out on a dermatome, right? And gives you shingles later on. And HHV6 can also stay in our body. It doesn't usually cause any problems later on. It just sort of is there, right? But in young infants, if you get HHV6, then it's often a cause of very high fever. And it's sometimes, as I said, a cause of like convulsions. They're the two main things, high fever and convulsions. Rarely, uncommonly, it causes other things like hepatitis and encephalitis and sometimes bone marrow problems. But most of us have had HHV6 sometime. We all had it, and it makes up about a third of all the febrile convulsions. Like even here, about a third of the febrile convulsions you see where a child has a fit and they have a fever and then they recover the next day. About a third of them will have had HHV6 if they had a very high temperature. It's not something that, you know, there's no treatment for it, but it's just good to recognize. Okay, yeah. Sometimes children who've had HHV6 can go on to have like a bit of scarring in their temporal lobe. That's actually quite common. They have like a febrile convulsion and then they might get a bit of scarring in their temporal lobe, and then they can go on and have some temporal lobe seizures later on in childhood. So a lot of the children that end up with what we call complex partial epilepsy or temporal lobe seizures, they will have had HHV6 when they were infants, right? Because it causes a bit of scarring. Okay, right. This is HHV6. This is the rash. You sometimes see, you don't always see the rash. Sometimes it just causes a very high fever, but this is the typical rash of HHV6. Okay. I want to go on to other fever and rashes now, and I'm going to talk very briefly about bacteria. So some fever and rashes are due to bacteria, and this is one that's also, again, quite common in PNG. I don't think we diagnose it very much, but it actually is quite common. It's a gram-negative bacteria, and it's transmitted by mites, like, you know, insect mites that get into the skin and transmit the bacteria. The mites are affected by the bacteria, and the bacteria is called Orientia tsutsugamushi, right? And funny name, but Orientia tsutsugamushi. And it was first described during the war. in especially in Asian countries and in Papua New Guinea, and it can cause like a lot of illness, like fever and cough and like pneumonia and hepatomegaly and lymphadenopathy. All those things you relate to, relate to some systemic infection. Scrub typhus, it's called. The main thing is if you see a child who's got fever and other systemic features, then look at them to see if they've got any mite bites, because sometimes they'll have Orientia tsuchigamushi or scrub typhus. Okay, it was well described during the Second World War and in the Southern Highlands and the West Sepik in about 10 years ago, and it's common in Cairns and Northern Territory in Australia, and it responds well to doxycycline or chloramphenicol. You can treat it quite well with those simple drugs, right? The distribution of the red parts of the map are where scrub typhus exists, and you can see it's all around our area, right? So that's where scrub typhus is. So look for a mite bite in children who've got fever and systemic features, and think of scrub typhus, because it's probably more common than what we realize. Yeah. Take a blood culture, see if you grow it. It might be quite common in some places. Then there's fever lasting 7 days, more than 7 days. And of course, that can be some of the things we already know about, like tuberculosis, or malaria can last 7 days, or rheumatic fever, or an abscess that you haven't found, and some sort of deep-seated abscess that you need to find. So these are all common like causes of fever lasting more than 7 days. Again, it's in the book and in the Hospital Care for Children book. And again, there's the diagnosis. The tables show the diagnosis, and then there's the clinical features that are in favor or against the different causes. So remember, when you see a child with fever, just think about, is it a fever with localizing signs, fever without localizing signs, fever with a rash, or fever lasting 7 days? And realize that there is overlap between all 4 groups, but it's good to think about each of them, right? I was going to just briefly touch on typhoid fever because it's so important, I think. And I think all of you know about typhoid fever. It's caused by Salmonella typhi mostly, but also Salmonella paratyphi also can cause typhoid fever. Most of them in PNG are Salmonella typhi, but there's also Salmonella paratyphi. It comes through contaminated water or food, right, which is different to typhus. Typhus comes from mite bites. Typhoid fever comes from contaminated water or food, and it's usually related to poor hygiene and sewage contamination of the water supply or food. And children present with lots of different features, diarrhea and vomiting and anorexia, abdominal pain, constipation, headache, often mental confusion. We saw a child this morning on the ward round, I think, who had probably typhoid with a typical typhoid facies. He was really blunted and looked depressed and had a blank, depressed appearance on his face. He wasn't responsive or alert or anything, but he wasn't unconscious. He could do what you asked, but he was just really blunted, wasn't he? Yeah, he probably had typhoid. And you see that typhoid facies, that typical facial appearance of children with typhoid in adolescents typically. But they might have splenomegaly or hepatomegaly or a rash. And yeah, this is the rose spot for typhoid. The rash of typhoid. We don't always see it, but sometimes you'll see it. It's probably, you won't always see it because it occurs several weeks into the illness, not right at the start. And the reason why it occurs if children are untreated is because they get it's like a miliary dissemination, right? They've got bloodstream dissemination of the bacteria. And if you were to take a sample, like sometimes I've taken a sample of the rash, if you put a little, like a needle and a syringe with some sterile saline injected into the rash and then aspirate the saline and put it on a microscope slide or put it in culture, you can grow the typhoid. So it tells you that if you see a child with typhoid and they've got this disseminated rash, they've got a disseminated infection, right? So, of course, if you do that and it doesn't grow, it might be because they're on antibiotics or because they've got a virus instead of typhoid. But sometimes you can find the typhoid by actually culturing the rash. It's a bacterial emboli into the skin, right? And so sometimes you can find the the bacteria by doing that, or take a blood culture. It can be easier. Right. The diagnosis is mostly clinical, and the features are non-specific, aren't they? They're, I think, much more specific is those mental changes. If you see that, in an adolescent, then it's probably typhoid. It could be other things, but think about typhoid. They often have leukocytosis or leukopenia, but that's non-specific too, isn't it? Their white cell count's high or low, and they sometimes have low platelet count. And the blood culture is the gold standard, isn't it? We used to do Widow's tests. The problem with Widow's is that many people in the community have a Widow's titer. Like if you go to the communities in Goroka, for example, many people will have like a 1 in 64, 1 in 32 Widow's titer. It's because we've all been exposed to typhoid at some stage. And we used to say, well, if it's 1 in 360, then we'll say, that's typhoid. But even that became hard. So I think it's gone away from being used, and the blood culture is better. But if you're in a situation, it's not, a Widow's test is useful, but typically you want to see a rising titer, like from 1 in 64 when they present to 1 in 360 or 1 in 124, 128 a week later. But that's usually only in retrospect, isn't it? You can then diagnose it only in retrospect. So blood culture is the way to go. Or if they've got a rash, sample the fluid. It's not bad to do that. The treatment, it's important to know what antibiotics will treat typhoid. And it's important to know that most of the typhoids now are, in some parts of the world, maybe not quite in PNG yet, but in some parts of the world, are resistant to the standard drugs we use to treat typhoid: ampicillin or amoxicillin, cotrimoxazole, and chloramphenicol. Most of them, more than half of them, are resistant. And so then you've got to use like ciprofloxacin or ceftriaxone, because most of those, the typhoids are sensitive still. Zero resistance to ciprofloxacin, for example, in Bangladesh and in PNG. So the first line treatment is now no longer very effective. We have to use those other ones, right? There are some parts of Asia, like India and some parts of Asia, where we're even getting like fluoroquinolone resistance, like to ciprofloxacin. That's a worry among typhoid, right? So we need to be careful about that. Yeah. Okay. All right. Now, I've only got a few more slides, but I want to say why a little fever is actually good for you, right? Because sometimes a little fever is good for you. And we sometimes think that all fever is dangerous and we should try to bring it down to being normal. Well, that's not the case. If a child's got a temperature of like 37.8 or 38 degrees and they've got an infection, then it's probably their body's way of fighting the infection, right? So, for example, bacteria, they don't survive as well when the temperature's high. All right, so the body makes a fever so it can counteract the bacteria. And antibiotics, they work better if the temperature's high than if the temperature's low. So we shouldn't always try to bring down the temperature to being normal. Obviously, a temperature of 40 can lead to seizures and can lead to other things, heat stroke even. But a little bit of fever actually is good for you. Does that make sense? So we shouldn't be worried if a child's got a bit of fever. It tells us something about their illness. And we know that, for example, if you look at children who've got a severe infection, the mortality rate is higher if they don't have a fever, if they've got hypothermia, than if they've got a fever. If you've got severe sepsis and you've got hypothermia, then you probably have a higher mortality. Does that make sense? So it's a little bit of fever is not a bad thing. Okay. 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 Now, I said at the start that we'd talk a bit about heat stroke, as we've been talking about pyrogenic causes of fever, haven't we? All the viruses and bacteria are pyrogenic. I want to talk briefly about heat stroke. We can also talk about this another day, but I think it's quite important because I think a lot of the children that we see, maybe sometimes they have heat stroke rather than virus or bacteria or parasites. This is some very, very old data over 100 years ago in Berlin. And I think it's important. Historically, it's useful to look at what was happening. In Berlin, there were many children. There's two things here. One is death rates, and the other one is fever, right? And July and August are the hottest months in Berlin, like in the Northern Hemisphere. And you can see that as the temperature was going up, the death rate was going up. And it's not related to more infections. It's because children were being exposed to very hot temperatures and with no way of cooling them down. And in Berlin at the time, there was a lot of bottle-fed babies, right? And you found that parents were keeping the milk. They'd have milk that was like cow's milk. There wasn't formula in those days. They had cow's milk, and they didn't have refrigerators. So the milk would become curdled and contaminated with infections, like with gram-negative infection. And then when the temperature is very high, like they would feed their babies like contaminated milk, and they would get infections, right? And so there's two things going on. One was the heat stroke of just high temperatures, and the other one was feeding with curdled milk, because it was curdled because the environmental temperature was so high. So this is an important message, I think, when we're seeing more bottle-fed babies, right? The contamination of milk when you've got high temperatures is very dangerous, right? This was Berlin. They showed a 4-fold increase in infant deaths over summer compared with winter, and it related to mostly bottle-fed babies who had a much higher death rate than breastfed babies, because there was no refrigeration, and the milk got contaminated with cow's milk with bacteria, and then these babies were presenting with diarrhea and severe dehydration. Interestingly, the babies that were living in the basements had a lower mortality rate, and that's because it was colder in the basements, right? Yeah, even though they were often, yeah, they were protected from heat stroke. Yeah. So I wanted to just discuss the features of heat stroke just very briefly. But just have it as part of your differential diagnosis when you see a really hot child. So they present with a really hot temperature, like usually above 40. Their core temperature is above 40, and they're red and they're hot, and they have very dry skin, and they have tachycardia. They often have a very strong pulse. They look like they've got severe sepsis. If they're older, they have a severe headache. So they're really irritable if they're conscious. Sometimes they're unconscious. And if they're older, they have dizziness because they're severely dehydrated. And they have nausea and vomiting typically. And they have mental confusion, and then they become unconscious, right? Yeah, this is, I think sometimes it's hard to distinguish from heat stroke from other conditions sometimes, but we see it sometimes when children are left in hot cars. You know, they're put in a hot car, and even if the temperature's like 25 degrees Celsius, the temperature inside the car can be 50 degrees, right? Inside a car. There was a child in Sydney who sadly died a few weeks ago, you might have heard, who was left in a car all day. The parent forgot to take the child to kinder, right? And so left in a hot car. And it wasn't like a very, very hot day. It was like just high 20s, I think. But of course, if you're left in a hot car, you can't drink, you get dehydrated, and you'll die of heat stroke. And I think probably there are some babies here that have heat stroke, not because they're left in a hot car, but just because they're exposed, into the hot environment, perhaps. Yeah. So just think about that. Yeah. Now, I won't maybe go into this too much, but I hope it's because we talked about the autonomic nervous system and how it protects us against heat stroke. When you've got heat stroke, then your autonomic nervous system is just overwhelmed. And usually the things that protect us, like moving into the shade or taking off our clothes or drinking or cooling ourselves down, for whatever reason, the children can't do that. And their autonomic nervous system is also overwhelmed. So they just get this rush of, blood to their skin to try to lose heat, but it's just not enough. And so when they get rush of blood to their skin, they get dehydrated as well because they're sweating so much. They lose all this heat, and then they get a lack of their heat control mechanisms, and because of the environment in which they're in, they have impaired behavioral responses. It's more common. We see it more common in infants, of course, because they can't decide to move into the shade. We see it more common in disabled kids who are older but still can't have the same behavioral response, and of course in elderly people who can't move around. You'll see heat stroke in elderly people quite commonly. They have dehydration, and that causes a reduction in blood flow to their bowel, and they then get the bacteria going into their bloodstream because they have like ischemic bowel, and they get reduced cerebral blood flow because they're hypovolemic and dehydrated, and they become lethargic and they have convulsions, and they go into kidney failure and have like multi-system failure. And so that's the end result of heat stroke. I think all I'm trying to really get you to do is think about it in your differential diagnosis and ask the questions about the environment in which the child's been for the last sort of 12 or 24 hours before they came in with a high fever. All right. The prevention is, I think we need to have some mechanisms to prevent heat stroke, and that's like a lot of parental education, isn't it? About how to look after your baby on a really hot day, and to make sure that, you know, they should give more fluid when the child has a fever or on a really hot day, and stay in the shade and use cool towels, wet towels to cool their baby down. If you see a child with heat stroke, then the only things to do are to try to reverse it as quickly as possible. It doesn't matter how quickly you do it, you won't be able to do it quickly enough. Try to do it as quickly as you can, and that means like cold compresses, ice packs on the child's body, intravenous fluids, put the IV fluids in the fridge or the freezer, cool it really down, run cold fluid into the body so that the child is getting rehydrated with cold intravenous fluids. Give some anticonvulsants because they're likely to seize. But those things that really cool the child down as quickly as possible might preserve their organ function, right? That's really all you can do. Obviously treat them with antibiotics because they might have a bacterial infection as well. Yeah, anyway. I think it's something we haven't talked about much. We think of fever as being just infections, but sometimes it can be a combination of infections and heat stroke. Just remember that. Okay, so we've discussed a lot of things today, but I think we'll just finish there. I'm happy to answer any questions that you might have, but I'll stop sharing my screen, and thanks for your attention today. Fever is a very important topic, so I hope you've learned something that we can help look after kids better. I'm going to stop recording now and